Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. You are listening to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and welcome to this week's episode. Today, I'm answering some of your fertility questions, and these are questions that were actually asked on a recent YouTube live. So starting to incorporate lives over on YouTube, which is a really fun way to connect in the moment, get a question answered, and ask a follow-up question. So today, we're going to bring you some of these questions so that you can hear them. I'm a big believer that sometimes you don't know the questions you want to ask until you hear them from somebody else. And there's just so many wonderful points covered in this episode. So this is a little taste of what you might get over on the YouTube channel. So go check out the YouTube channel at nataliecrawfordmd. Couple housekeeping items before we dive in. Please know you can also ask questions on the As a Woman voicemail, on Instagram, and in the newsletter. You can sign up for the newsletter at nataliecrawfordmd.com. And the newsletter comes out every week, has recipes, my favorites, little updates. It also has a freebie for the TTC Starter Guide, which is just the high-level points on cycle tracking and some of the tips that I recommend before you want to get pregnant, which is a question I am asked all the time. Newsletter subscribers have other fun access to getting questions answered. So do not forget to sign up for it. It's not spam at all. You can ask questions on Instagram on Monday. Some will be answered in the newsletter, some on Instagram, some in the podcast. And if you do want to call and leave that voicemail, you can call 657-229-3672. Every year for the holidays, we do a lot of Q&A episodes. Those are coming up. So get your questions in before we dive hard into these Q&A topics. Today's really a big potpourri of a lot of different fertility questions. So dive in, listen, and I hope you enjoy. Welcome to Fertility Q&A live chat. So I've got some questions that were asked ahead of time and appreciate you guys submitting some, but if you put some in the chat, we will start prioritizing those once they get there, but we've got some questions to kick us off. So hopefully this is something that we can do more often because I know I cover a variety of topics, but answering your questions is my favorite thing. So I am going to just jump on in. So one of the first questions is, if you're married and ready to start a family now, is it a good idea to freeze eggs for the second and third child, or can freezing eggs interfere with your natural fertility? For example, if you freeze eggs on October 15th, could you try to conceive naturally on November 15th, or would there be a long recovery period and adjustment? So this is a very good question, and there's a couple points to it. The short answer is that freezing your eggs or freezing embryos for the future is not going to impact your natural fertility. It will take you out of the game for 1 month, so that month that you're going through the process. But after you have your period, you're back to normal and you can try immediately. Remember that it's not making you run out of eggs any faster, because the way I like to think about it is that remember, you've got the vault inside your ovary where I like to think about all your eggs being kept. And every month you have a group of eggs come out of that vault. Normally, one egg is going to respond to ovulate and the rest are going to die. So in its simplest form, when we think about egg freezing or embryo freezing, we're just trying to get the eggs that you would normally have die, get them to grow, and then take them out of the body. That happens right around the time ovulation would. And then afterwards, you'll get a period a couple weeks later. So we're not running out of eggs any faster. We're just helping more eggs that month have a potential for later. And you can try the cycle after. That's not a problem at all. The bigger question is, should you save eggs or embryos for the future? And honestly, that is a little bit more complicated. It depends on how old you are and the spacing of your children, and if you are pregnant or if you get pregnant quickly or not quickly. So I think that if you know you want to have kids and you know you want to have a bigger family and you're getting started later, 100% where you're coming is a smart answer, because being able to utilize those eggs or embryos later is going to make the journey a lot easier. I always frame it to my patients when we talk about this. Will it be impossible for you to get pregnant or get eggs or embryos at that time? Probably not. Will it be markedly easier the younger you are and the more you have? Absolutely. Okay, we've got some questions in the chat, so I'm hopping over there. Will a slightly elevated prolactin level impact my fertility? Prolactin is a hormone which is made from the pituitary gland, and so are the hormones FSH and LH. So remember that FSH, follicle stimulating hormone, is what gets an egg or a follicle to grow. So FSH comes from the pituitary gland, tells the ovary, let's grow an egg. The egg starts growing and making estrogen. And then the pituitary gland is going to sense that high estrogen and send out an LH surge so that you'll ovulate. Prolactin can be high in a variety of different circumstances. So sometimes it's high because you have an adenoma or like a little area in the pituitary gland where you have more cells that make prolactin. It's called a prolactinoma. It can also be high because you have stimulation, like nipple stimulation can cause it to be higher. Sometimes medications can cause it to be higher. Exercise or sex can cause it to be higher. So prolactin varies throughout your day and in response to different things. But in general, prolactin should be checked when you have irregular abnormal cycles. And one thing we know is it definitely can cause some ovulatory dysfunction. At really high levels, when your pituitary gland is so busy making all that prolactin, it's not going to send out any FSH. And so you're not going to ovulate. So high prolactin levels, no ovulation. And so it should always be checked if you're not having periods. As prolactin lowers, we've seen people with treatment that will normalize. So you'll go from no periods to irregular periods to having them coming every month, but not quite at the same time, what I call irregularly regular, and then a short luteal phase and then normal. So one of those first signs of dysfunction can actually be a short luteal phase. So that's what you might be more apt to see with that slightly high prolactin. The way that we treat this is often with a medication called cabergoline. And what that does is it lowers your prolactin levels. And one of the other questions that we had is, can you continue it if you're trying to get pregnant? And yes, I have my patients continue cabergoline or bromocriptine or Dosinex, but then you'll stop it with a positive pregnancy test. Last note on prolactin, because we've got lots of good questions here that we're going to dive into, is that it varies based on time of day and where you are in your cycle. So if you do get an elevated level, I recommend repeating it in the follicular phase, so the first part of your cycle, in the morning, fasting, to make sure that it's a real value. Okay, is there a way to find out how many eggs are left? Yes and no. When we think about inside the vault, there's no way to know exactly how many eggs you have remaining. However, what we can do is that we can check factors and evaluate the eggs that that vault is sending out every month. And the more eggs that the vault sends out, the more that are remaining. So the way that we check this is an antral follicle count, AFC, and you can check it with an AMH, which is anti-Mullerian hormone, a blood test. Both of these things can vary, so it really confuses people. If you have an AMH one year and the next year it's higher, like how did I get more eggs? And I think that's why we have to remember we're evaluating what you have this exact month, and we're using that as a representation for what's inside the vault, knowing that when you have more eggs, more are coming out. And when you have fewer eggs, fewer are coming out. I've gone to the doctor. I'm healthy. She said, I have a low egg count, but I'm 36. How does one prepare for pregnancy? So anytime you have a low egg count, that doesn't mean you can't get pregnant. When we think about those eggs coming out of the vault, one is going to ovulate, the others will die. So your body doesn't care if it's having 5 that die or 20 that die. Couple big picture items is that if your egg count is lower, you might have less time to grow your whole family, and that's a fact. So if you're starting later and you want multiple kids, we really want to think about that. The other thing is the question I always ask is why? Why is it low? Do we know why? Maybe we do. Maybe you had a big ovarian cyst removed, or maybe you had endometriosis, or maybe your mom went into menopause early, or maybe you have a known autoimmune disease. Sometimes, though, we don't know why, and it can be this little red flag that is starting the investigation to see if whatever caused your low reserve could cause you to have infertility as well. When you're trying to prepare for a future pregnancy, so what do I do if I want to get pregnant? I recommend you really start treating your body like you're pregnant now and just taking care of yourself. So remember that inflammation is just really toxic to so many body processes. So what we're going to want you to do is get good sleep. That's when your body heals inflammation. Eat lots of whole foods. So kind of get rid of the processed foods, the sugar, stop drinking, stop smoking cigarettes or marijuana. exercise, move your body, try to maintain a healthy weight, and really start tracking your cycles. So if you've not tracked or you've been on contraception, see if you have regular cycles because you can identify something abnormal before you get started. And then from a vitamin standpoint, prenatal vitamin, folic acid, you want at least 400 micrograms of folic acid. And I recommend that patients also look and make sure that their prenatal has omega-3 fatty acids and that it's going to have vitamin D in it as well. I've been off the Depo shot for a year and I still do not have regular periods. I've been having an awful ovulation pains for weeks, but could I have PCOS or is there something lingering from the Depo? Either. It could be both. So one thing that's really important for people to realize, because Depo-Provera is used for preventing pregnancy. So that's a birth control. So that's the birth control shot. And it is proven to prevent ovulation for 3 months. However, it can prevent ovulation for up to 18 months. So I have seen you in my office. Somebody says, I took Depo a year ago and I still don't have a period. And that can be perfectly normal. That being said, I still, if you're a whole year past and you don't have period, then I would recommend, or you have irregular cycles, that we get an evaluation, which would include looking for PCOS and ultrasound, and also checking that thyroid and the prolactin to make sure there's nothing else that could be contributing as well. All right, these are great questions, you guys. So keep them up, and we are going to try to go through some of them quickly too, so we can get to answers. And if you guys are enjoying the live, we will make sure that we do more of them in the future. I read that red light therapy is good for mitochondrial health and egg quality, but common sense makes it difficult to understand how light can penetrate deep into your body to make a difference. This is one of the things that I think we've got to remember, that your whole body is a whole unit. And I totally agree. I can't directly put red light on my ovaries to impact my eggs. But things that decrease inflammation in your body as a whole and make you feel better and decrease your stress can also impact your ovarian health and your egg quality. Egg quality is the percentage of normal genetics inside the eggs. And the analogy that I always like to think about is that those DNA has been inside the ovary, inside those eggs, your entire life. And it's like having kindergartners stand in a line. And the longer they stand in line, the more likely they're going to get out of place. And so if you're older, you have a hit on your DNA because they've just been there a long time. But other things can get them out of place too. Like think about distractions. If there's a lot going on, they're going to get out of line. And I view inflammation as that distraction. So red light therapy kind of falls into the camp with a few other alternative therapies that is probably very individualized, meaning not everybody responds differently. And it's probably more impactful in the whole sense of helping you decrease stress, helping you decrease inflammation. And that is more of the road where it could potentially have a beneficial impact on your egg quality. What's the average number of IVF cycles for stage 4 endo at 30 years old? In POI, which is premature ovarian insufficiency, and I'm trying to gear up for what I should expect. When you have POI or premature ovarian insufficiency and you have a low egg count for your age or very, very low egg count, stage 4 endometriosis can be one of the causes. So Chelsea, huge hug to you because it sucks a lot. In your favor is your age. So being 30 is really in your favor, and you are not going to need as many eggs as somebody else might need. However, I would really think about what is your antral follicle count, because that's an expectation of what you may be able to get. And then I would think about what is the likelihood of those eggs making it through. So if we have an antral follicle count of 10, which would be about half as much as you should for your age, and we got all 10 eggs, we usually see fertilization rates of about 75 to 80%. So that would be 8 out of the 10. About half of those would make it through to a usable embryo, which would be 4 out of the 8. And if we did genetic testing, you should have about 70% genetically normal because of your age. So that's so good. At age 35, 36, it's more 50-50. At age 40, it's more like 25% normal. So being 30 really is helping you, even if you don't have as many eggs. And the scenario I just gave, you had probably 3 normal embryos. One single genetically normal embryo has a 65% chance of resulting in a baby. 2 would have an 88% chance cumulative, not put in at the same time, but either getting pregnant the first or the second transfer. and 3 is 95%. So when we talk about helping you have success, I want to get 2 to 3 embryos for every child that you want to have. And how many cycles that may take can be really individualized. So it is probably going to take more than one, pending the severity of your POI, but it's something that I have patients perform above and below average. That's what average is by definition. So definitely don't call yourself out of the game and don't psych yourself out. Really look at what is the best I can do and see if your cycles are meeting that. All right, I have an embryo transfer scheduled for next week. And what are things I can do to help the embryo stick? This is where I like patients to pretend they're pregnant until proven otherwise. Remember that the number one reason why embryo transfers do not work has nothing to do with anything you did or didn't do. It's the embryo's fault. Not every embryo is competent, meaning it has the ability to turn into a baby. Even if it's genetically normal, cells have to divide, organs have to form, and there's a lot that has to happen to get from embryo to baby. So I say take care of yourself and take care of yourself to be healthy. And these are not mind-boggling things, but I want my patients to, make sure they're using their progesterone at the right time, make sure they're getting 8 hours of sleep, make sure they're lightly moving their body. This is not the time where you should run a marathon. No, thank you. This is not the time where you should be trying to lose a lot of weight. This is where you should be really thinking about how can we eat at home and cook food and have a lot of nourishing foods, not be in calorie restriction, not be in a high inflammatory state. So try not to overthink it. Just think about, I'm going to take care of myself so that my body can feel like if this is the embryo, it will stick. I'm 48 and trying to conceive naturally my second child, just like the first one, 15 years ago. My AMH is 0.21, FSH12, LH6. Do you have any tips for increasing my odds? Unfortunately, at age 48, it's going to be tough. It's not impossible, but we would say your odds of success are going to be ultimately really low every single month because of that genetic factor. The vast majority of your eggs at age 48 are going to be genetically abnormal. I would say if you are having regular cycles, the best you can do is really make sure you know when you're ovulating so you can time intercourse the best. There's so many different options, whether it's temperature tracking or whether it's ovulation predictor kits. Everybody's going to like something a little bit different. I think ovulation predictor kits, which is the urinary OPK tests, or anything that's telling you when you are ovulating before you do, is one of the best things you can do because that's going to help you really, really make sure you're at least timing intercourse. Most IVF clinics won't do IVF with your own eggs at age 48. So I know that puts you in a hard spot because if you showed up to a lot of clinics, because so many eggs are going to be genetically abnormal, most people are going to tell you that donor eggs is going to be the best option. And I know that's tough too, but remember that there's a lot more that makes a family than just DNA. And so many people have added to their family or grown their family using donor eggs. And it really is a really beautiful thing. So, see a fertility doctor to at least learn more and get information on that. All right. Is it likely to have intracycle bleeding while trying to get pregnant? Some say implantation bleeding is not real. Is there more hormonal variability with trying to conceive that can lead to bleeding? Okay. I love this question. Should you bleed in your cycle? No. Can you bleed and it be perfectly normal? Yes. Can you bleed and it be really abnormal? Also, yes. And so let's think about that. Bleeding around ovulation is probably the most common time that is very, very normal because what happens is when that follicle ruptures, let's remember that the follicle, the egg grows inside, ruptures for the egg to come out. The cells that make estrogen are surrounding that follicle and they get disrupted with that rupture. So it's very common to see your estrogen drop and then rise again once that corpus luteum reforms and starts making estrogen progesterone. That estrogen drop can cause you to have some periovulatory spotting. Should not be heavy, should not be like a period. That's very normal. I don't worry about that at all. Implantation, bleeding, spotting is the idea that when the placenta is growing in, it's eating away at your blood vessels, which is true. And some of this blood starts to escape out. That is also can be normal, but it shouldn't happen in every cycle. You're not going to have implantation in every single cycle. And typically we think that implantation bleeding should be more red or pink, less likely to be older looking blood, like you might see period spotting. If it's happening in every cycle, if it is happening right before your period comes, if it looks darker or older, that is more concerning to me, that the luteal phase is not being quite as strong and that might be a problem. So that is something that I would want to get evaluated. You guys, there's so many good questions here. So I'm definitely going to try to just answer a few more of them, more rapid fire, so we can get through some of them. Is your AMH level important if you're already in POI and you're taking hormone replacement therapy? I'm 21, so not relevant at the moment. This is one where it might depend. If you have no eggs remaining, you're truly in POI on hormone replacement, I would expect your AMH to be undetectable. If you have any follicles, a very low AMH, that might be an opportunity to stimulate. I start viewing more on clinical symptoms in these very low findings or FSH levels more than AMH. I've struggled to get pregnant with my second for a year. February, I had my tubes cleared out. I then got pregnant and miscarried. I haven't been able to get pregnant since. I'm so sorry. I do think that that's a long enough time where I would make sure you've completed out the rest of the fertility evaluation. And there's so much more that can play a role. Secondary infertility is a real thing. And there's a lot of different reasons why that we want to make sure you don't have going on. My wife and I have been trying to get pregnant for a year. It seems like as soon as I ejaculate, the semen comes out. Is this normal? Sperm come out of that ejaculate in seconds. And there have been studies showing that sperm are outside the fallopian tubes literally in 1 or 2 minutes. So it's normal. Most of the ejaculate is going to come out the vagina because what its job is to do is just protect the sperm from the acidity of the vagina. I have endometriosis. I'm 38. I don't have kids. Can I use my eggs to do IVF? I checked my AMH 2 months ago. It's 2.98. And what would you advise? The normal AMH level, again, marker of how many eggs that you have at age 38, is typically going to be closer to 1.5 to 2.5. So a level of 2.98 is great. That sounds above average. If you have endometriosis, we know you have a higher rate of infertility and a lower probability of pregnancy per month. So when we have that, we want to make sure that you are doing everything you can to set yourself up for success. And if you're not ready for kids yet, doing IVF and freezing eggs or embryos is the smartest thing that you can do. Endometriosis is both inflammatory and destructive and can definitely impact your future fertility. Anything else we can take or do to improve our chances of conceiving besides take care of yourself? I know that answer always feels non-fulfilling. Track your cycles. So many people will wait or try for a year and then come to see me and we realize there was some issue within their cycle. So think about the red flag warning signs that should be evaluated sooner. Are your periods regular? You should be able to look at the calendar, put your finger on a day, and be very, very close to where you should be ovulating or to where your period should be coming. Are your periods so painful? If you cancel plans with friends, that's not great. Can you tell when you ovulate? Do you have pain with sex? Can you have sex? Are there erection or ejaculation problems? So really make sure that you know those factors. In my perfect world, you would track your cycles for 3 or 4 months before you're even ready to get pregnant so that if your periods aren't regular or you can't detect ovulation, we can jump in really, really fast. 44, soon to be 45. I've never been pregnant. Last month, I fell pregnant naturally and had a chemical pregnancy. What can I do to help myself and lower the chances? I'd strongly consider IVF if you have the resources or the ability to do so, because genetics are going to be really limiting. If we're talking about naturally, what can you do? This is something where really, really trying to lower your inflammation is truly the only thing that you can do. More than 90% of your eggs are going to be genetically abnormal at this stage. So it's going to be keep trying and people can get pregnant. So keep trying, take as good of care of yourself as you can. If you want to consider IVF, you might have a limited opportunity for that. So I don't want you to lose that option. Can you take an acetylcysteine for recurrent miscarriage at 5 weeks pregnant? I don't have patients take it once they're already pregnant. For me, that's something that I have them take ahead of time to see if it can help with implantation. My period's on time, but it's missing this month. I took a pregnancy test and it's negative. Can I still be pregnant? Sometimes you ovulate late. So take a pregnancy test again. If it's still negative, everybody's entitled to a weird month. But if your period is going off 45, 50 days, and it's normally truly every month, go see your doctor so we can make sure something isn't going on. Is it possible to find multiple follicular cysts in an ultrasound and still have normal testosterone and other hormones? Is this PCOS? A follicle is a cyst. A cyst is a fluid-filled structure. So if you are age 20, age 30, I would expect you to have 20 or more follicular cysts in your ovary, that's your follicle count. So I would not be at all concerned. Now, if they are saying I see 40 antral follicles or something very high, that might be a concern that it's something a little bit greater, but you're supposed to have eggs. So to me, I would just say that looks like normal follicular cysts, normal follicles that are being seen. Where are you located? I'm in Austin, Texas. My doctor did a blood test. Everything looked good except my LH was 0.2. That can be a really normal LH value, especially in the follicular phase of your cycle. So I'm not worried about that unless there's other things that are going on, like we're not having any periods at all. During your periods, when's the best day to start Clomid to avoid early ovulation? Clomid has been studied and he's usually started on day 3 to 5 of your bleeding. So day 1 is the first day of full flow, and usually somewhere between days 3 to 5 is going to be best. Clomid itself works by blocking estrogen receptors in the brain. And so it should cause most people to ovulate a little bit later just based on mechanism of action. All right. Oh my gosh, I love you guys. Is a 4AA embryo the best to implant with assisted hatching? Embryo grading, number, letter. The number is about how expanded it is. We're usually looking for 4s or 5s. And the first letter is like school grades. A is awesome, B is good, C is not so great. The first letter is the embryo itself, and the second letter is what's called the trifectoderm or the placenta. 4AA is an excellent embryo. You really can't get better than that. But embryos that are not as pretty can still make absolutely beautiful children. So I wouldn't let that hold me back from transferring an embryo. After an FET, we're expecting twins. It was a single embryo transfer. Are there danger for my wife or for the babies? So when you transfer a single embryo and it splits, this can happen in 2 to 3% of IVF cycles. So that's not that rare. Different types of twinning can happen from what we call monozygotic twins. So they come from one zygote, one embryo. Those twins can be in their own sacs and have their own placenta. That is the safest option and has really minimal risks. The next option is that they can be in the individual sacs but share one placenta. That has more risk because they can steal blood supply. One can grow faster and steal from the other. More risky is what we call monoamnionic, monochorionic. You'll hear them referred to as MOMO twins. And this is essentially 2 babies in one sac, one placenta. Their cords can get entangled. They are much riskier as they get older to have fetal loss or have a stillbirth or be born really, really early, and they require more monitoring. And so it really depends on what type of twins. It can be minimal risk. It could be something that does require much more monitoring. Somebody just said, I love the interview with Andrew Huberman. I learned so much. Thank you guys. If you haven't seen that one, it is linked on my profile and it is also over on Huberman Lab as well. 4 follicles, 1.03 AMH. I'm 35. I start IUI in January. I need 6 failed trials before IVF. If IUI works after pregnancy or before, should we freeze embryos sooner than later? We want 2 kids. So a lot of times this is either a clinic requirement to have 6 failed IUIs, or it could be an insurance requirement. Everybody's a little bit different here. Freezing embryos sooner than later will help you have a higher chance of getting pregnant in the future. However, if you only want 2 kids and you do get pregnant really soon at 35 and you more promptly start trying for that second, you should still be at a place where you would have a good opportunity for conception. The thing in your prompt that worries me is 4 follicles. An AMH of 1.03, we should see closer to about 10 follicles. And at age 35, we should see closer to 15. So if we're having lower ovarian reserve, freezing embryo sooner is 100% going to be smart, because that will be harder when you have even less eggs in the future. AMH 2.81 in my 30s, that's a really normal level. What's your tip for people with PCOS going into first ovulation induction procedure? When you have PCOS, you have more follicles. I like to usually think about the brain doesn't know this and sends out the same FSH signal, and that signal is getting diluted amongst many, many follicles, so it's not strong enough. When you do ovulation induction, 2 main ways that it is done with oral medication. One is Clomid, one is letrozole. Clomid has been around longer, is more studied. Letrozole is the drug of choice for PCOS. Big studies have shown that. Letrozole works by lowering estrogen levels in your circulating blood system. Clomid works by binding estrogen receptors. Clomid has more symptoms. Clomid can cause persistent cysts. Clomid can also cause a thin lining. So we really prefer letrozole as the first line of action. My biggest tip for somebody is, what are they gauging to know if it's working? Because really, when you're doing your first ovulation induction cycle, there's a little bit of trial and error, because it's not that more meds will make you respond more. It's that people have a threshold dose of when it will work. So working is getting you to ovulate. I mean, we would love you to get pregnant, but the medication working is getting you to ovulate. And if you're not ovulating at this dose, we should step it up. So are they checking an ultrasound? Are you following OPKs? Are you checking a mid-luteal progesterone? Understanding, how do you know I did ovulate, and what are we going to do if it's negative? My favorite way, if you get to choose, would be that you are seeing for an ultrasound, because if nothing is happening, we can immediately stair step you up and get you to that ovulatory dose faster. But a lot of times, if you're seeing a general OBGYN for this step, which can be super normal, they may not have the resources to do that. How much is your fertility decreased if you lose one fallopian tube but still have both ovaries? You can still get pregnant. It's really only a minimal decrease depending on why you lost that tube. So if you lost the tube because of an ectopic pregnancy, that is really different than if you lost the tube from endometriosis, because that endo is still going to exist and still can impact the other fallopian tube as well. So when we have one tube, I always like to think about it as there really is a, what do we think caused that problem with the other tube? And is this an isolated incident? For example, I had a patient who had a ruptured appendix when she was younger, and then her right fallopian tube was really dilated and had a hydrosalpinx. And the right side of the body is where the appendix is. So taking that tube out, really feel like that's an isolated scenario, and she got pregnant with just the other tube really quite easily. So it really is going to depend on what is happening here. I strictly have a 25-day cycle and still no luck not getting pregnant. 25-day cycle can be very, very normal. Although the one caveat I like to say here is, have you had your ovarian reserve checked, and has your cycle always been 25 days? One of the first signs that you're having an lowering of your ovarian reserve can actually be having a shorter cycle interval than you used to have. And that's because your brain starts sending out a stronger FSH signal and you're ovulating a little bit sooner. So anytime I see somebody with a shorter cycle interval, I'm always thinking to myself, what is their egg count? Is this normal? And is there something else that we should do to intervene? How do I know if I have low progesterone, and is this causing a miscarriage? I had 2 chemical pregnancies. My menstrual cycles are irregular, 42, 50, 70 days. My luteal phase is normal. My partner smokes. Having your partner smoke cigarettes or marijuana can impact miscarriage. It is associated with a higher rate of miscarriage. So number one, that's probably the strongest factor you said that is an issue. Number two, when you're having irregular cycles, we are concerned that if you don't make a great follicle to ovulate, that you're not going to make a great corpus luteum, which makes progesterone. Number three, low progesterone is how an abnormal pregnancy communicates to the body. So that's tough, right? Because if the pregnancy is not normal, let's say it's genetically abnormal, it is not going to have as high of HCG. And HCG is what you test on the pregnancy test, so it won't be as dark. And the darker that HCG is, the more it's telling your body to make more progesterone. So if it's really light, it's telling your body not to make as much. And that's almost the signal to have you miscarry because something's not normal. That being said, low progesterone is a real thing, and it can be an issue for certain people. If you have irregular cycles, we should do ovulation induction, and you can consider adding in progesterone. I would not add progesterone alone because, it's like boarding up a house or trying to repair a wall when the foundation is really not there. So let's ovulate a better follicle. Let's get you to ovulate better and have regular cycles. We can still fix up the interior or add on the progesterone, but we really want to have that good foundation. But real heart to heart with your partner about the smoking, because it's not secondhand smoke. It's truly about how that's impacting the DNA of the sperm. And sperm is one of the easiest things for us to change because eggs are inside the female body your entire life. So they've already absorbed some wear and tear that we can try to impact the future ones. Sperm is brand new sperm. We make one change. These new sperm are seeing something totally different. So that definitely is something that we can change in the future.
I'm 42. I'm recently diagnosed with adenomyosis, and can I have another child? Adenomyosis is an inflammatory response, and in the simplest way to describe something quite complex, typically happens after you've had uterine surgery or a baby. And it's where these endometrial-like cells get into the myometrium, or the muscle of the uterus. So a higher cause of unexplained infertility and secondary infertility, meaning you had a baby first and now you're trying to have another baby and you're having trouble. Adenomyosis can cause heavy, painful periods, but essentially it's an inflammatory response inside the uterus itself. Very often we are going to need to do IVF. And I know nobody wants to do IVF, but the reason why IVF can be so helpful here is that we are able to kind of get those embryos out, and then we can give you some medication to really shut down all of that inflammation. And you can't do that in a cycle where you normally ovulate, because inflammation is important in the ovulatory process. So I think that is so hard. There's one last question here, and I'll just say, what about people who've never had kids or surgery? I'm 33 and I don't know why I had it. Should I go straight to surrogacy? Complicated question. I wouldn't go straight to surrogacy. If it was me and I had this diagnosis, I would do IVF and get embryos. You've got to have that for surrogacy too. But I've seen good success with patients as long as we do the right protocol, really trying to suppress that adenomyosis. And that's typically by using Lupron or high-dose Lupron.
All right, friends, I hope you enjoyed this week's episode. I know it was a little different, and we will be back to your regularly scheduled content soon. Don't forget to follow along on Instagram at nataliecrawfordmd. Every year, we do a big survey about the content you want to see, and that is when we plan all of our episodes for the next year. So when somebody asks, how do you have ideas and how do you keep up with it? It comes from you. I spend my time creating content to help educate you about your body and your fertility, and it's because I want you to learn. So look out for that on Instagram so that you can submit your request. That's at nataliecrawfordmd.com. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd, and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.